You have anything to say to anyone, a dentist, a patient? What do you want to say, if anything? Any recommendations or?
Well, I don't recommendation for dentist, but for myself, am I doing wrong things to my patient, like me doing to myself? What have, well,
You could just say you're speechless.
yes,
Okay, wait a minute. So what do you have to say now that you've seen this? What do you
Oh
think?
gosh, I guess I'm speechless because it goes.
we run so hard for
Because I guess CR is not
CR.
enough.
No. So where are you from?
I'm from Palembang, Sumatra Island, Indonesia.
Indonesia? And
I came here because 2 years ago I got hospitalized because ear pain.
right?
My right side have ear pain after I turun from aeroplane.
Or after a plane ride.
Got it.
Yes, they the doctor sees nothing. I got MRI. They say nothing here.
Okay.
Then I put my splint, and I think maybe full mouth reconstruction would help me. It did. And then they put it on October 2014. And January they equilibrate, they pull out the onlay and everything to equilibrate on articulator.
Yes. So they did it artificially out in vitro on the articulator instead of
Yes,
in your
but
mouth.
when that happened, my temporary crown is falling, and then I never feel it comfortable.
Okay.
So it got pain, and eyes make me pain. I make myself splint. It helped.
You're a dentist. We need to be
Yes.
clear here.
I am a
in-
dentist,
in
and I
Indonesia.
make myself splint because no other dentist makes splint.
Yeah.
But after 3 weeks, it come again. I reline it, it's better.
Right.
And then I realize it. I feel there is space between my lower teeth and upper teeth.
And that's a new thing.
Yes, it is. 2 leaf gates, and then 3 leaf gates, and then 4 leaf gates
Over what period of time?
every month.
So 6
Every
months.
month?
Yeah, 6 months it became 4 leaf gates.
Got it.
Before it is very comfortable now. It
Now-
hit here and then it hit here.
I understand. It's kind of pivoting. It's so your bite is opening. You're getting an anterior open bite. It sounds like.
At that time, I
Yeah.
don't have courage to make my adjustment. I'm afraid of making mistakes, so I wait here
I understand.
till I meet you.
So you're both dentists. This is your daughter, right?
Yes.
Yeah. Where was the equilibration done? Was it done in the States or back home?
It's in California.
California, yeah.
Okay. Okay, so you were doing great. They pulled off the posterior armlays, gold work, and they, on the
Equilibrate.
articulator, put it on the models, and well, why did they decide to do that? What was
It was
their-
just a step that they always do. So
Okay. Was it like a dental school setting? Was it a private practice?
it was more of a clinical private practice setting.
Gotcha. Okay. I'm just curious. Do you have trouble chewing gum?
I never do.
You never do. How about chewy foods like steak or something that's really like candy?
No, I cannot because I cannot.
Clench.
Yeah, I cannot cleanse.
Is that something that's been ongoing for many years, or is that something recent?
Something recent.
So you were this was a non-issue for you before last.
Last year, no.
So the genesis of the problem was an ear issue, or in front of the ear. I need to be specific.
At the back of my eye, my nose, and my ear is feeling full.
Was it like Okay.
like a ball here.
Understood.
Sometimes it feels small, sometimes feel like pushing.
pressure.
Big pressure.
Mhm.
But when I'm hospitalized, it was pain, really, really painful. And then I wear my splint, it's okay. And then I decide to wear splint is, my bite is not the same anymore after
Right.
splint. So
Okay, so the fullness in the ear, you feel like it's in the canal. Your sensation, and by your estimation, subjectively, you think it's in the canal, right?
Yes.
It's not in front of it, it's not behind it.
it's here. Here.
It's inside of the ear.
Okay,
No,
well,
here sometimes, yeah, and then here.
Okay, all right, I'm not, okay. All right, because a lot of times within the ear canals, that's more of a, that can be potentially cervical. Like 2/3 of the innervation comes from upper cervical vertebrae. So, yeah, so when people come in and are concerned about the ear canal, like I had another patient I just left a few minutes ago, like just finished, you know, that's one of her issues. We knocked out everything else like right now, but she's still got a little bit of the tinnitus going on, and that's cervical. You know, people will have macro traumas, they'll have whiplash injuries, they'll fall out of trees when they're kids, they'll, you know, we looked at your stuff yesterday, the cone beam, the 3D imaging, your growth centers, they're stunted, you know, you're small. So we know there was damage way back when you were young, you know, not that you're old, but you know, when you were a kid. So that's a contributing factor. But the point is, I say all that to say, if you damage your neck, guess what else you can damage? Your TMJs. You got ligaments connecting cartilage to bone in the neck. You got ligaments connecting cartilage to bone in the TMJ. But most don't realize that, hey, if I have a car wreck or a fall, I shouldn't just check my neck, I should also check my joints. They don't do that
Yeah.
because it's standard of care to ignore the TMJ. Because why? Because there's so much conflict as to what's right and what's wrong and what to do, and nobody has a consensus. So everybody just throws their arms up and they say, oh, the TMJ patient is a freak, it's psychological, there's nothing going on there, let's make them squint. You know what I mean? I assume it's the same in Indonesia.
Yeah. The
They
doctor
have-
just give me drugs.
Yes, a pill, right? Yeah, so the reality is most of it's biomechanical, anatomic, physiologic. There's reasons for all this, but you have to measure. If you don't measure, you're not going to find it. Yeah, you make splints, you affect a temporary change, and it's not a reversible change much of the time. It can actually cause damage. Yeah, so that's, I don't care what mainstream says, I don't care if anyone listens to this and they have an argument with it. I'll tell you my experience, you know, so people come to us specifically, a lot of them, to get off splints. So, and I'm not going to stop all parafunction. You know, this is going to go to dentists, this video. This is not going to be for the public. I cannot stop parafunction. I don't want to stop parafunction. That's not pathology. That's not a problem. You know, clenching and grinding is the central nervous system's way of catching the bite up to where the joint wants it to be. Because I think I told you guys this yesterday, the joints are the two gods and the teeth are the minions.
Yeah. Yes.
And they're slaves to what the joint needs because that's where the hinge is. That's where it all, and it's a living thing. It changes a little bit. Teeth do. Bone remodels. Cartilage as we age gets a little bit smaller and a little bit drier. Compressibility goes down. Bearing zones vary slightly. There's vascularity to the posterior band, the anterior band, and everything in between. You've got synovial fluids. You know, I'm not knowledgeable enough to say what happens in synovial fluid. You definitely have some kind of intracapsular damage. You have an issue because for you to have that stunted condylar head surface area, you had to have disrupted your growth center. And in a child, minimally that's a lateral pull. And you know, so at least your lateral pull is torn forwards, per the CT. Not that I can see your cartilage, but I can extrapolate based on what I've seen. So I can measure developmentally what's going on, and then I kind of put things together. It's like a detective. You know, unless I don't have the MRI on you, a proper MRI, that'd be awesome. But so the bottom line is, you know, it could be that the straw that broke the camel's back was the minion pissing off the joint. The most likely, most plausible explanation is that you just had degeneration. That was coincident with the timing. It probably didn't, It may have had a little bit to do with the centric thing. It may not have. Here's a worst case scenario, for example. You have blood supply coming to the condylar head from the medial aspect, and if the cartilage gets torn further medially anterior, you constrict that blood supply, you can start killing off the bone, avascular necrosis. You know, you've got to change there. The bone could die. You know, a little bit of an open bite, that could have been resultant of, you know, your splint treatment, or it could have been because you have a foundational issue in the joint itself. If the vertical height of the joint starts decreasing, things pivot off the back molars, so the front teeth start opening. You know, so we don't know without an MRI for sure where you are right now, and we wouldn't know where you were last year because we don't have an old MRI to compare it to. Do you have trouble sleeping at night?
I always wake up several times.
Yeah.
It is been years.
So that's something you ongoing.
Yeah.
You got sleep apneic or something,
Yes.
right? Yeah. Okay, so that's not changed since this has happened, or has it?
No.
Okay. You wore braces years ago, is that right?
Maybe 25 years ago or 30 years. Yeah, something like that.
Yeah, and as I recall, they extracted premolars.
Yes.
Yeah, probably, I'm extrapolating again, but we talked about this yesterday because you had a, developmental issue on your mandible. Disrupted growth centers. Mandible never grew to full genetic potential.
Yes.
Maxilla kept going, so they popped out premolars and moved things back on the maxilla and forwards on the mandible to try to get a class 1. When the reality is they didn't recognize the issue was the fact that you were short back here. Back here being in your joints and the ramus. Remember we were looking at how small that condylar head was? And the neck of it?
Yeah.
You know, the ramus that reaches up to the condylar head? Yeah, so, my point is that because the mandible never grew all that way forwards, and we were kind of talking about this yesterday a little bit about sleep apnea, it kind of blocks off your airway. You lose a tongue bubble and then you lose pharyngeal thickness, the width, in the pharynx itself. I don't have a full field of view cone beam. If I did, we could look at that, but I don't have one. I'm sorry. Mine's medium. I'm working on it. It's another $150,000 I gotta save up. So, did anyone ever try to, shoot a cone beam? Has anyone looked at that yet?
For the airway?
Yes.
Well, just for the joints in general.
Yes, 1 month ago.
Yeah?
I got a group in Indonesia
Yeah.
to learn TMJ, but with Okesan.
Okesan?
Yeah, it's the Occlusion group in Indonesia. They have
They have one over there? Oh, I didn't know. Yeah. As in Jeff Okesan, as in University of Kentucky, Jeff
Yes.
Okesan. Yeah. Okay. So they have like a
It's
training.
Galileo's, and they combine it with the CCAP program.
Yes.
So they were doing the imaging, and then I think they did
Yeah.
a prediction on the movement of the joint.
Alabama professor orthodonty, how to.
So what did they do?
They just said that maybe it is the wrong splint.
Okay. May I ask if you guys know what position did they shoot the cone beam in? Was it fully seated condylar position like CR? Was it MIP? Was it translated? Was it open? Size ledge? What was it?
I think it's CR.
So they actually put a bite block in before you. Did you rest your chin on a platform or did you bite on the stick? Do you remember?
Bite on stick.
Yeah, that's going to be like what we're. That's slightly translated in size ledge position, slightly open. Okay. And it was a Galileo, so it was a full field of view. You don't happen to have it with you, do you? No? Okay. All right. That'd be nice to compare the old and the new. But the splint affected it. It was helpful for a short time, and then it was
Yes.
no longer helpful.
After 3 weeks, I feel uncomfortable on the same side, and then I reline it. After reline, I feel it's lighter again.
And then it happens again in 3 weeks. So this one's just being used as a distraction method.
Right. Understood.
But maybe because I reline it myself, it's not right.
That's it.
Well, in other words, you're throwing yourself into CR. Are you building it to fully seated? Do you have a long centric in your splint? How are you doing it? you have anterior guidance. What are you trying to do with your splint?
Sitting it in CR, there's an
Yeah.
anterior guidance and a canine guidance,
Okay.
not along CR. So.
There's not. So there's no real freedom in centric. You're trying to lock her down at CR?
Right.
Okay, that's not a good idea. Let me tell you why. Because of all the positions, the orthopedic position, the centric relation, or it's only centric relation if things are totally normal, if you have discs stably interposed between bones, right?
Mhm.
And ligaments are in perfect shape, and retrodiscal tissue is nice and proper. That's the only time it's centric relation. Most of the time, people don't have this beautiful undamaged Piper 1 joint. They have something that's damaged. I know yours is damaged because we know for sure yours is
Yeah.
damaged based on the condylar surface area, right? So it's either adapted centric posture or non-adapted centric posture. So what does that mean? Well, wherever the heck I bimanually manipulate, as long as I get the teeth separated, you know, go up. Wherever the tissues are, that's where I'm going to wind up. That's fully seated condylar position. If you just say that one thing, FSCP, that encompasses CR, non-adapted centric, and you know, adapted centric posture. So
Yeah, on CR.
yeah, here's the reason why FSCP is a bad idea. If you have any trauma to your cartilage, it's going to start at the 1 o'clock position, the posterior band, right? The cartilage is stably interposed, medial and lateral.
Start sliding,
aspects.
okay.
The first thing where you're going to start losing cartilage between bone is in the fully seated position. Because things always tear anterior and slightly medial. So fully seated is never the right, I shouldn't say never, that's bad. Now here's the absolute key, per Piper, by the way. This is not my discovery, this is his. The goal is to have the condylar head stably interposed with minimally medial ligament. In other words, if you've torn lateral, okay, but you have to have medial. You have to, so in other words, in the ideal world, you're a Piper 3A or better, and I DTR you, I nail it, okay? But when you start messing with medial pole, as I told you guys yesterday, things get a little less predictable. But my point is, if you build a splint in fully seated condylar position, CR, whatever you want to call it, if it's going to get torn, it's most likely to be torn forwards of that position. It can't go any further back. So if it tears, it's going to go, you might have it stably interposed at MIP, you might have it stably interposed at IEP, you might have it stably interposed at, kind of translated open, but you're in trouble by then. So why do you think the Pankey and the Dawson people, most people are trained that way, and then every now and then they freak out that dentist didn't help them, they find an LVI guy and they feel better. Because the cartilage is down and forwards. It's got nothing to do with tensing the muscle. It has to do with where the hell the cartilage is. Okay?
So that's why downward forward works sometimes.
Right. They're all right some of the time. They're all wrong most of the time. All those people being all the different camps. Like, I'm not going to say names anymore. I got to be nice. But I don't care if you're dealing with centric relation. I don't care if you're dealing with MIP. I don't care if you're dealing with incisal edge. I don't care, downwards and forwards, 4-7 position, whatever. The reality is, so what happens to the patient that has, say, no cartilage anymore? There's many of those. Then you're dealing with the retrodiscal tissues, and then people talk about pseudodiscs. And pseudodiscs, you don't get those truly in adults. Now, you were a child, or probably a teenager when you messed up your growth center. So an MRI would show us if you had something, that's kind of fibrosed in the retrodiscal tissues and become a pseudodisc. But adults themselves, if you had damage as an adult, you're not going to form a pseudodisc. This is per Piper. Thousands of surgeries later. Okay? So these things I regurgitate, it's not all me. I'm a disciple of Piper and Kirstein and me and others. I'm like a blender mixing all this stuff together and observing. Yeah, but my point is, you are more likely to, for example, worst case scenario, pull that disc further anterior medial and cut off that blood supply to the condylar head and cause an avascular necrosis if you build that splint and fully seated.
Which is what we've been doing.
That's the point. Now, I don't think you have avascular necrosis because, from what I understand, per Piper, it's not my thing, I'm not a surgeon, but if you have an AVN, you wake up one morning and your bite is wide open. It's not just a gradual thing. Like you're saying a leaf gauge a month or something like that, that's gradual. That sounds like degenerative change. That doesn't sound like ADN. ADN, the way I've been told, I've never seen it yet, knock on wood, but they'll wake up one morning and they're like, I can't even get my teeth together. It's like, and it's lopsided depending on which side broke down. Yeah, so, but it's highly suggestive. So here's the bottom line. You say the past few months I'm starting to open up. It's either splint, or it's degenerative change. It's possibly a little bit of both. So we'll try this, we'll dial you in. So I'm going to catch your bite up to where the joints want your bite to be. But if it's still degenerating up here, you're going to wind up being open a little bit more next month, a little bit more next month, a little more next month. See where I'm going with that? Unless someone like Piper goes in and intervenes. Because it's backside issue. I call it backside and front side. You know, I can do a little bit of change. I can make the minions kind of influence the joints on the DTR, especially when it's lateral pull or better, right? But when you start talking medial pull, those joints, they have full control. I can balance the bite to where the joint wants to be today, and it should improve some, but you may find as it breaks down in the back, the minions are starting to separate again. Minions being the teeth.
So time would be the great
Time will tell.
diagnosis.
Yeah, tincture of time, you'll see. Now, I've had cases that are far more scary than yours, based on the information I had. And there's many cases I say I can't help you, and I send them straight to the surgeon. Yeah, you're not that case, but you're close.
I'm close to that.
Yeah, see, and you guys understand.
Yeah.
And it's not scary, it is what it is. You know, the bottom line is, I think we're kind of like this last stop before Piper, is what it's turning into over the years. You know, that makes sense? And I treat to MIP. Why do I do that? Well, I'll tell you real quick. If I have a torn cartilage, a torn disc, my lateral pull is going to go first. My medial pull will go after the lateral. It's a tighter ligament, right? So I am, at MIP, I'm more likely to have medial pull stably interposed between condylar head and glenoid fossa, between the bones, right? Even if my lateral pull is torn at MIP, I'm okay with that. You know, that's not that big a deal. The only time it affects the change is in the excursions. And guess what we work in DTR? The excursions. We shut down muscle through the excursions. We're not worried about these static bites and all these CRs and all this together stuff. I don't even look at that. Everything I do is in the excursion. And guess what happens when you have a torn lateral pull? Think about it anatomically. It has to do with lateral pull is where you pivot off of. See where I'm going with this? That's a little deep. Most people don't think that way, but if you open your mind to what actually happens and where you're rotating on cartilage, it's in the excursions the lateral pull matters. And what matters in static bite, whether it be fully seated or MIP, is medial pull. But if I'm going to have a medial pull torn, it's going to tear out between the bones at fully seated before it will at MIP. Hence, statistically, even if I'm ignorant completely to the status of the cartilage, I'm not completely ignorant because I'm measuring space where the cartilage should live on CT. But let's say I didn't even have CT. I'm better off treating to MIP. Because the cartilage is more likely to be there at MIP than it is fully seated. So all the camps are right some of the time, all the camps are wrong most of the time. The only way to really know is to measure it. Does that make sense?
That's why in the beginning you said you don't really care which camp as long as you know where the cartilage is. Because
Yes. If you know where the cartilage is at, that's the first key, and you have to be able to measure. Just like, you know, everyone thinks this is all T-scan. No, that's front side. But I can read T-scan data and I can read into backside stuff. I can read bites. Piper taught me this. I can read bites at MIP in an incised ledge position, canine edge position. I can get a feel for what the cartilage is doing just by looking in your mouth. I almost don't, I need an MRI to do it right. My point is, there's all these clues, these things that we're not taught in school and all the camps don't ever tell us. Okay? So if you ask yourself, why are we making changes so rapidly in what we do? I'm trying to explain to you guys why.
Because you're using the MIP as opposed to relying on seated
Yes.
condyle, because you don't really trust, you don't really have your MRI data.
Well, think about it. The normal human being doesn't sit around in CR chewing their food. You know, that's almost like pull your shoulder back all the way and walk around like this. You don't do that. You rest right here. It's a postural position. And the pterygoids, you know, MIP, you're posturing forwards a little bit.
Right.
Right? So that's a natural state. So why would I fight the system? Why would I build someone's bite to fully seated? Because, no offense, Dr. XYZ told me so in Florida or wherever they may be. You know what I'm saying? It's like whatever institute. Just because they said that, why does that mean it has to be? It doesn't make sense. Why would you build a CR? Because, like I said in summary, the cartilage, if it's damaged, is most likely to be out of place and fully seated. So if you're building a splint to CR,
Fully seated.
or fully seated, let's call it fully seated because it's not CR with you. It's adapted or non-adapted centric posture. With you, it's 100% non-adapted centric posture.
See the changes.
It is not adapted because it keeps changing. Yeah. So another rule we're going to break is we're not supposed to do what I'm doing on a non-adapted joint. So you guys, the reason I'm not saying you have to leave and go to Piper right off is because you understand this. A normal patient that didn't get that, I'm being honest, I would say you guys have to see Piper. But you guys understand this. So this is informed consent, right?
Yes.
Yeah. So because you are in a non-adapted state, this is tricky. We're going to try, we're going to do our thing. We're going to watch the muscle shut down. It's not just about force and time. We're going to see how you feel. You know, that's subjective. Honestly, I don't care how you feel until the end of the day. But I'll ask you, and you'll tell me. But that's all subjective information. And we're going to see what happens, and let's see what goes on. So you guys got any questions? I know I started to talk too much, but...
No, we just... I know she's going to watch the video again and again and like...
I'll post this. You guys, it'll be a long one, but we can do that.
Yeah.
And this whole talk. In my mind, if I can't do something with my own hands, it's wrong. You know what I'm saying? So over the years, everything I've learned in dental school or in CE and all this stuff, if I can't do it myself, it's not true. Maybe I'm limited or ignorant, or maybe I don't have the dexterity, perhaps. Or maybe there's a lot of smoke and mirrors to it all. So just because someone says I have to do something this way, doesn't mean I have to follow that. If everyone's jumping off the cliff, that doesn't mean I have to jump off the cliff. Yeah, so years ago, about 8 years ago or so, I was really fed up because my CAD/CAM fixes, I'd have hypersensitivity, I'd have a little bit of, spasm afterwards, perfect contacts. The occlusion was better than what the lab had made me years prior when I was only using labs, which I never use anymore, ever. Never say ever, but maybe once every 2 months I would take an impression. That's it. Everything's digital. It's all, and I design myself. Why do I design CEREC on my own? Because I don't trust anyone about the occlusion. Because of my knowledge of what I do in this room, this kind of stuff, I know in general dentistry, what I need to do to not introduce these errors that can mess with lateral pull and cause chronic pain, and or the medial pull. A bite's not going to mess with medial pull, right? But my point is, open your mind to forget what they taught you in school. Don't forget it. Don't ever forget anything that you've been taught. But always question, and if you can't see that result in your own practice, there's something wrong here. So years ago, I was trying to figure out what the big mystery is with CR, right? And I'll never know it all, but I know more now, and I can actually speak intelligently about it, and I've seen hundreds of people. I'm not going to say names, but I've seen patients that have seen the supposed gurus, and they're worse. I'm not going to say names. And did we help them? Most of the time. Did we ever make anybody worse? Nope. Did we identify when to refer off for surgery? Yep. Were all indicated for surgery? No. So that's why I keep trying to build this protocol. I'm trying to get predictability. I got to figure out what is the most important. Development and degeneration. And stability. And proof positive that the front side is out of whack. If you have an anterior open bite, guess what T-scan is going to give me? A record of the fact that you had an anterior open bite. Because when you bite on the sensor, I'm not going to have little blue marks on the front. Yeah, and I actually have a record of the occlusion. So why doesn't every dentist on the planet have a T-scan? Think about that. You have records of everything else.
In Indonesia, we never heard about this scan, only
Yeah.
from DentNet group. You said about
DentNet?
Yes.
Oh, you were on the DentNet?
Yeah.
Yes, because I have.
I didn't know you were on the DentNet.
I never thought.
You should give me a high five. So she's heard me bitching them for years.
Just the last
I
four.
have the
Yeah.
the oldest 3D. I don't have the Omnicerex.
Yeah.
Yes.
It's all right.
That's why I want to ask if I give her what's the first, T-scan or Omnicerex?
I think the T-scan first.
Actually, I disagree. The CEREC first.
Really?
Oh.
Yeah.
Oh.
Well, you should get them both. Bite home hard. Now rake. And open. Good. Now we're going to go home. We're going to clench for a good second. We're going to rake left and then open. Don't close yet. Bite home hard. Rake. Open. Perfect. MIP, I'm working the excursions. MIP always works itself out. That's the last thing I don't ever worry about it. See the silent periods? See that nice little silent period right there?
Yeah.
Probably saw that in undergrad, and probably a little bit of dental school, but nobody knows what to make of it.
What is that?
That's central nervous system testing the waters to make sure it doesn't break a tooth. Getting better. Later back. Except see that kink, the way it went, it was going east and it went north? That's called a mid-course correction. That's gotta go bye-bye. You feel a little easier to clench now, isn't it?
Yes.
Okay, bite home, rake to the right. Okay, open.
She asked me why we're touching the left side. She's still not touching at all on the left side.
Doesn't matter what she feels.
Oh, okay.
What matters is the data. Trust me on that.
Okay.
I don't care how you feel. That sounds wrong, but I do.
Mhm.
At the end of the day, I don't care right now. But I want to hear that. That's okay. You can tell me whatever you want.
Mhm.
But do you understand where I'm going with this?
Okay.
This is why you can't trust the patient. You can't trust the rivet.
Okay.
Okay, home, left. And that the balancing interference is the bad thing.
Yeah.
The reality is, the group function is worse than the balancing.
Oh yeah.
You don't ever put it on the back molars, anything behind. You want it on the anteriors as rapidly as possible. And you have a compromised situation if you have implants up front and natural teeth in the back. That's not good because you've got
You don't have
neurologically and dead.
proprioceptor anymore.
There's nothing. Yeah.
Nanti ngomong tahun ini nggak ngerti.
So it's not a.
People learn to avoid it.
That's called a compensatory response. So then muscles get spastic and then they're generating lactic from a different reason. So what if I told you, like, when your mom gets to chapter 8, she'll read my chapter that I wrote, my textbook chapter. But what I didn't write in there because I couldn't really support it
Because you couldn't record it, okay?
was I'm almost sure it has to do with sympathetics. By the way, we got any ice? What do you feel like right now? I mean, whatever you feel, tell me.
I feel it is more lighter, but being a dentist,
Yeah.
I feel it's not like all thick. It is this, three.
Feels uneven.
Uneven, yes, but
Yeah. But less.
I
Go ahead.
don't know, less lighter here.
Less tension on the temporalis.
I think so. I don't recognize it before, but yeah, it's more lighter here.
A little looser, right?
Yeah.
Here, do me a favor. We're not done, but we're about midway. Switch for me. Give me a number.
I can stand it. Maybe 5.
Different than it was.
Before, I'm so afraid. Ooh.
Right. Just
So big difference.
No, yes.
for a heck of it, do it again. Be sure. Guys, let's get a real good to cover up that. All this plume is hitting all these cords.
The upper, the pain in the upper is gone.
Yeah.
Only in the lower and the side.
Yeah. I've worked mostly your right side. So I'm not done. I'm just, point is it's changing already. Yeah.
Yeah. The sharp pain is gone.
See, so you create a perfected occlusion, and then you Xerox that anatomy and you perpetuate it with CAD-CAM. Or you do CAD-CAM and then you check your bite at the end if you're doing single tooth stuff. Not everybody can get DTR and it's expensive. Okay, home, left, okay? Don't close yet. So speed bumps going down on a micro level. Tap, tap, tap. Drip, 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 drip. So what's that do over time? Fires up the sympathetics. Not only that, you got neurology that directly through the PDLs and intrapulpal fibers ramps up the muscle. You got two different ways of causing problems. Sympathetics and then masturbatory
Happy. No tension.
Happy with no tension?
Mm-hmm.
All right, 0 to 10.
I don't know, say 1.
A 1?
Here, maybe 2. Okay.
A 2? Oh, I'm so sorry, it's still a 2. Do it again, make sure. She's not even acting surprised. She's just like, oh, it's just a 1 or 2.
The right side is gone. Only the left side still.
Little
But I
bit.
never realized I have a painful at the...
From cold. Most people don't. It's a minor thing. But see, theoretically, either it's got something to do with torsional flexure of teeth, or it has something to do with sympathetics. And I really think it's autonomic. I don't think it has anything to do with trigeminal nerve. I think I've knocked out the tap-tap phenomenon, so the cold is no longer angering things. I think it has a little bit to do with bending of teeth excessively when muscle's working too hard. Now muscle's more efficient, and it starts shutting down. Move your neck around and everything. Do you feel different? Does it feel kind of loose?
Yes.
But compared to when you walked in, describe for me, if you would.
I feel tension here. No.
Now no tension.
No tension.
Yeah.
Yes.
And the temple?
And the temple gone.
Gone. And you didn't even really know you had it, did you?
Yeah.
Yeah, isn't this crazy?
Wow.
So here's the lesson to dental profession. Dental work throws people out of whack. Like completely. Makes people miserable. So if you don't measure your dental work in space and in time, look at the kind of crap that can happen. Yeah, so think about how this changes everything. Fillings, sealants, all the state boards that allow assistants to drop fillings in and drop sealants in, even the dentists themselves don't know what they're doing. They're all using ribbon. And people wonder why they have problems. Why do you, so basically we make everyone an annuity to dentistry. Do you think 500 years ago people broke teeth very much? No. Because there was no iatrogenic introduction of a glitch in the whole machine. This is a new thing. This is kind of like top secret, right? So not only are we ramping muscle up and causing pain, breaking teeth, and adding to our pocketbooks kind of indirectly through ignorance, we're causing like TMD pain, we're returning lateral pulls, we've got TMJ problems going down.
We don't have...
It's a big deal. This stuff's a big deal because if you really start thinking outside the box and you realize that, and look, we looked at you and we were all worried about your joints, but nature adapted, right? You have small, tiny condylar heads, but look, you're doing better all of a sudden, aren't you? You feel pretty good right now, don't you? Is it better than it was?
Yes. Now I can feel my left side.
Yeah. Things are, I mean, look, I'm not going to push it much harder because I don't want to I don't want to run the risk of punching a hole through your gold crown. So compared to when you walk in, are you glad you had it done?
Yes.
Make a difference?
Yes.
I've seen her this happy since she started wearing the splint full time.
So she started or stopped?
Since she started wearing the splint full time.
That's
so
funny.
many years.
You have anything to say to anyone, a dentist, a patient? What do you want to say, if anything? Any recommendations or?
Well, I don't recommendation for dentist, but for myself, am I doing wrong things to my patient, like me doing to myself? What have,
You
well,
could just say you're speechless.
yeah,
Okay, wait a minute. So what do you have to say now that you've seen this? What do you
Oh
think?
gosh. I guess I'm speechless because it goes,
we learn so hard for
because I guess CR is not
CR.
enough.
No. It's just a diagnostic position, to be honest with you.
There's much more to
Yep.
figure out.
So, thank you very much. Because what questions just arose from three dentists sitting here today right now? That bite can throw you into trouble.
Right.
You've experienced it now.
Yeah.
So what are we doing to our patients? We're not measuring things. We're using a typewriter ribbon, basically. You know, and that smudges are maybe at best 20% accurate, at best. Right? And this is not an advertisement for T-Scan. You know, that's the only thing out there, unfortunately. And it's not 100% either, but I'd rather use something 95% than 20%. That's common sense, right? Yeah. And then all of a sudden, if you start studying Kirstein's research, you start understanding how the muscle reacts. And all of a sudden, if you read my research, which is that stuff, you start thinking about what you kind of learned about the cold thing today. All of a sudden, you've got different ways of, so we're addressing PDL, we're addressing A beta proprioception out of the pulp, which you probably don't even know exists. There's A betas in the pulp, just like you got touch here. In 2008, they tracked it to the sensory homunculus. The dental pulp is part of the sensory homunculus. What is the inside of the tooth doing with proprioceptive A beta fibers? A deltas and C's we know about. A betas, what's it doing there? Torsionally flexes teeth. Remember, the wind's blowing too much, the
Right.
muscles bending the tooth too much.
This
and then-
almost makes me think that those meridian tooth charts might not be too crazy.
It's not, well, there could be something to it because of this reason that I'm bringing up. And then the sympathetics have to do with a little bit of the bend, the tap-tap phenomenon, and the cold. So all that crazy autonomic stuff we learned our first year, way back in the day in dental school. So it's not all sensory, it's not all trigeminal. I'll tell you what, I'm going to give you an assignment. I'll build your video, and then you take the link and you post it on DentNet and you tell those guys what the hell is going on.
Okay.
See you later. She's like, hell yeah.
I'm thinking to bring the video to my group in Indonesia.
Yeah?
You want to travel to Indonesia and give a speech to the Oakland group there?
Oh, you're kidding? They kicked me out.
No, they're actually pretty open-minded. It started because a lot of them are CEREC user, and then they're trying to figure out to troubleshoot because of the issues that they have. That's why they're traveling. It's not just.
Well, that's how I got into this stuff, because I had issues with CEREC, even though it was better than lab, I still had issues. So when you start applying, all of a sudden you start thinking outside the box. 10 years later, this is where I'm at. All of a sudden I'm fixing people that other people can't fix. For fun. It's not that profitable. I make more money per unit time normal stuff.
Yeah.
Yeah.
My wife wants to shoot me every week. Kill for kids.
Sorry.
Careful, careful.
So
We
now
don't touch you.
your splint, what are you going to do with your splint?
I don't use it anymore.
Now you're gonna make sure she doesn't use her splint?
I'm gonna make sure, and I think the explanation why, was really helpful.
Sufficient? Okay.
Absolutely.
Alright.
You're gonna start having more people from Indonesia joining DentNet because I knew she convinced a couple of the organizers to join.
Well, we're getting ready to go over the textbook. You know that, right?
Yeah.
Yeah, that's a big deal. Hodish and I got together with Xana. You know we should push that. This is a big deal. Big deal. One last time. 0 to 10. What's your number?
Or you can.
2, 1.
And what were you an hour and a half ago?
Oh, I don't want to.
You don't want to think about it much, do you?
Yeah, I don't want
I want
to.
to test myself. I'm like,
Oh.
okay.
What are you?
One.
A 1?
Yeah, nothing really.
You're probably not too bad. See that? There's a quick screening.
Mm-hmm.
If you,
This is the quick screen, okay?
it's a down and dirty, really quick thing.
You will getting better after a few days.
You?
Yeah,
Maybe. You should. Yeah.
because it is still.
Well, ischemia, you have to give things time.
Mm-hmm.
Ischemia, you need to get reoxygenated. You have to
Yeah.
flush the lactate. You should get better and better and better, as long as it's not joint. And by the way, your leaf gauge thing, that's subjective. It's analog.
Oh, okay.
And when you were spying on T-scan in the beginning, you were touching anterior.
Mm-hmm.
So, see why another reason I don't trust all the old dogma?
Mm-hmm.
The digital showed me that you're contacting. There's a 100 micron thickness to the T-scan sensor, 10th of a millimeter.
Mm-hmm.
But the reality is it doesn't really activate until you're down to about the 20 micron range. So all these guys and naysayers that say the same thickness all the way front to back, that throws things out of whack. Ribbon has a thickness. Ribbon tears. You know, there's nothing perfect. But the reality is you are touching. So that's good. See, you were telling me, oh, my front teeth aren't touching anymore and all this. No, 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 this is good. I don't think, I know you got a joint issue that's developmental,
Mm-hmm.
but hopefully it's not that bad degenerative. You know, time will tell. It'd be nice to track you like in a couple years to see how the joints are doing. Now, a bad thing, if your front teeth really do start opening up, that's breakdown up here. Because your dental work's clear now. You're in the A range. You're not A+. We'd spend all day because of all the gold work. But I knew you were good enough when I saw it. And you can tell yourself, it's like, damn. Right?
You know that's Alyssa's
Yeah.
coffee.
So, all right.